Welcome to 7 Investing Now, a show that teaches you how to take a long-term view on investing by better understanding what's happening in the market now.
Good afternoon, 7 investors, and welcome to the Monday edition of Investing Now. You can't tell, I'm in a beige box, but I am coming to you from beautiful, I'm coming to you from downtown Miami. My name, of course, is Daniel Brooks Kline. I'm the host of the program. I'm going to be joined today by Maxx Chatsko. We're going to try to talk about 3 different things. I'll explain why I use the word try in a second. First, we're going to talk about what I consider the next frontier in telemedicine, at-home testing. We're going to follow that by talking about what's next for mRNA, and then we're going to talk about AbbVie. There is some news there today. Why do I say try? Because I parked in 2-hour parking, which expires at 1:39. So we're going to try to go 30 minutes today so my car doesn't get booted. I am on my way to 4 days at sea on a cruise, so we are going to get right to it. We will try to work in your questions and comments. So Max, let's talk a little bit about at-home testing, because I had my first experience with it. And here's how I see it. It's happened 3 different ways. One, you get a kit and you log in and you do a telemedicine. Mine had to be proctored. Someone had to see me stick the thing in my nose and get a negative COVID test. So that's number one. 2 is where you either self-administer or mail away for results. Or 3 are tests where a nurse comes to your house as part of a telemedicine appointment. Max, my test was easy, took about 20 minutes. It was a little nerve-wracking, but I, of course, got a negative result. But is this the next step in telemedicine and making healthcare more convenient?
Yeah, so this is called distributed diagnostics, Dan, and it's kind of an up-and-coming field. It's only really made possible now. We've had some, advances in chemistry, so we can have different things power those kits and those tests, so we can actually ship them to you at your home, and you can get somewhat reliable results. However, there is always that trade-off between convenience and reliability, especially here, for diagnostics. It's kind of similar to like in tech, right? There's that trade-off between convenience and security. Ideally, everybody would be using like 2-factor authentication and logging out of, their bank account or whatever it is every time they weren't on that web page. In practice, they don't do that because it's not as convenient to type in your password every couple hours or whatever it might be. Same thing here. There's always that trade-off. So for things like, a COVID test, it's a pretty simple detection. So that makes sense. Obviously, we have things like pregnancy tests are pretty widespread, right? But yeah, there's always going to be that limitation of how reliable, how accurate can it be. There's always some amount of error. And of course, as in the last 2 years, we've learned how many dumb people there are in the United States. So you have to make your tests work for millions and millions of mouth-breathing morons out there. And you have to kind of simplify it and dumb it down for them.
None of you, of course, qualify as that because you were here watching us on 7 Investing. Now, yeah, it felt a bit like a pregnancy test, albeit I've never taken a pregnancy test. You put a little solution in, you swab your nose, you sit for 15 minutes. There's a control line, looks like a minus. And then if another line comes up, you have it. If it's faint, you have to go get another test. If it's strong, you're positive. Mine didn't come up at all, but I took my test on Saturday because if there was a positive, I would have had the option of going the next day or that afternoon of taking the more invasive test, which would tell if it was a false positive. But Max, is this something that pharmacy chains like CVS might move even further into? And what would that look like? Because obviously they have a big physical footprint.
Yeah, 100%. I think that's really the next step in distributed diagnostics. Maybe it's not so much at home as much, but more in community settings, right? Rather than you going to the hospital or maybe some specialty care center, maybe you could do this at a pharmacy or your local, your PCP office, right? Your doctor's office. And that's really, again, it's something that's made possible through, just advances in chemistry, advances in diagnostic kits, maybe even some hardware that might be coming, like your local doctor's office might eventually get a sequencing machine or something like that, right? So then we can run even more advanced diagnostics. And that could be possible at Walmart or CVS.
I could see a lot of ways for people to screw up the proctored part of this. I have a web camera. I did it from my studio where we tape 7 Investing Now. The average person trying to do this on an iPhone, you have to make sure you keep the thing in sight because it invalidates the test if they think you're sticking, the nasal swab in someone else's nose. And we've obviously seen with COVID that there's people, who might try to do that. So there are some potential holes in this. Max, I know you're not familiar with the Amazon program, but what Amazon is doing, and they've extended this to some other companies, is they have telemedicine. And if the doctor decides, hey, we need to take your blood pressure, or we need a blood sample, or we need a urine, whatever sample it might be, there are all sorts of horrifying samples you can be asked to give. They will dispatch a nurse. Do you think that's something where we're going to see this more hybrid model become more common?
Yeah, I know that kind of also is taking off a little bit in the pandemic, right? There's certain areas of medicine, like rare diseases, for example, you do need to get drugs. It doesn't matter if there's a pandemic or zombies are attacking or whatever. So if you can't make it to your doctor's office, and in normal times, some people just can't do that. So we have seen models like where nurses come to you, and that has that's more of a niche, I think, in the air in healthcare. I'm not sure how widespread that can really be because there's some practicality issues with the availability of nurses and going into people's homes if that's safe or not, and all those weird, wonky things you have to consider. But yeah, I mean, that could be more common going forward.
Yeah, I will point out that the person who proctored my test was likely not a nurse. They were likely just a person who was trained to make sure I stuck the swab in my nose and threaded it through correctly on the test. Max, can this go too far? You know, I talked a little bit about, I had a minor, let's call it allergy, that I thought I might need some medicine for. And I went to a telemedicine thing, and it gave me a list of medicines that I could pick from. And in theory, a doctor looked at it. But to me, that felt like a little wrong. Like, you know, and my symptoms got better. It wasn't a big deal. So I ended up not doing it. But that seemed to me like maybe as a patient, I shouldn't get to pick which medicine I want.
Yeah, I mean, there's always gaps in these processes, right, and how these work, and that's again one of the limitations of distributed diagnostics. And is this going to work exactly like with going into your home? It's probably going to be in some type of controlled setting somewhere. We can still take away some of the friction and pain points there, but again, making it at a pharmacy or a Walmart or something like that. But there's this emerging field called biosimulation, and there's a new tool within that called virtual twin. There's a couple different companies that are trying it. It's already actually used in certain drug developer or certain drug developers are using this to kind of optimize the design of certain clinical trials. So virtual twin they make a copy of you, Dan, on the computer, a simulated virtual version of you.
And nobody wants that, Max.
No, that's why we keep it on the computer. So we throw everything at it. We can say what happens to Dan if we give him this dose of drug or that dose of drug. Or does he have any interactions, drug-drug interactions they're called, with other medications he's taking that maybe we don't want to trip that up, right? So we can kind of predict these things ahead of time. So that's probably that sounds reasonable to me that can roll out to, again, your doctor's office later this decade, and it's just going to optimize because right now it's kind of a one size fits all approach. There's some amount of drug that we give you at this frequency, this often. But as you take that drug, eventually your doctor might tune it to you a little bit. So if we could do that ahead of time, it could be safer. We could have better outcomes. Maybe it could roll out. Again, this would be a perfect match for distributed diagnostics as well.
It also seems like an excellent video game we could play with celebrities that maybe we don't like see what you can do to the situation by throwing different drugs at him. Okay, that is a little bit silly. Feel free to get your questions and comments in. I don't know that we're going to get to a ton of them because, as I mentioned, we have a bit of a shorter window today. If you are not a 7 Investing member, now is an excellent time to join. Why? Because on Friday, we do our members only call. What happens in the members only call? It's like 7 Investing Now, but you can ask us questions about any of our past recommendations. We'll also talk about some of our favorites. We'll give some updates. So if you are not a member, it is very easy to join. Go to 7investing.com/subscribe, and you can pay us either $49 a month or $399 a year. That is a tremendous value. We also have an $84 student membership. If you are an active student or buying the membership for an active student, if you have a student email address, it will likely go through. If you do not, just send us an email at info@7investing.com, and we will make sure to take care of that. But Max, let's move on to MRNA, which I incorrectly spelled in all of our documents. It is a little m and then capital RNA, not Mr. NA, as I more or less wrote it in our documentations. Though that would be a really good name for a mysterious wrestler who messes you up so much he changes your DNA. I'm working on this as we go. Are we going to see a lot more mRNA-based vaccines?
Yeah, absolutely. So I think as the pandemic showed, mRNA as a technology platform is ideally well suited, perfectly suited for making vaccines for infectious diseases. So absolutely, Dan, we're going to see more. But investors have to take into consideration a couple different things, right? Because in the news we're talking about Moderna is combining different vaccines into one, right? So maybe it would have a pan flu booster, meaning like could protect against different strains of the flu, which whatever's circulating that season. Maybe it would also that same injection would also include a booster for coronavirus, whatever strain or variant might be around at the time, and actually included another vaccine for RSV. It's a different type of virus, like something that older individuals need to be protected against. So that's interesting, right? It opens up these new opportunities to combine things into one shot for more convenience, all of your protection at once. Seems like a no-brainer there from an infectious diseases standpoint. However, there's so much like people are really misinterpreting, I think, a lot of this, right? We developed these vaccines for the pandemic because we had to. We also prioritized their development. They unveiled that is going to now be in development, this, flu coronavirus vaccine combo, but it's going to take years to develop it. They're not going to have this on the market in a year or two or anything like that. By the time this eventually might be on the market, coronavirus might not even really be that big of a threat. I think most people will probably have protection for it by then. So investors do need to kind of keep their expectations in check. And historically, I mean, vaccines are big business, but not anywhere on the order of what Moderna is going to pull in on an annual basis in this year, maybe next year from the coronavirus vaccine. That's, $20 billion, maybe even $30 billion. But for things like the flu vaccine, there's so many different companies like offering, products for that. It might peak at like $5 billion per year. So there's going to be an issue with trying to replace the revenue from this year and next year as that kind of starts to fall off.
And Max, there's been some fool's gold here for investors, right? Like, so company has a hit drug, it gets up to a huge valuation, and then it sort of doesn't always or almost never live up to that. You actually created a chart if you want to launch into that.
Yeah. So JT, if we can pull this up. So of all the drug developers that have ever reached a $100 billion valuation, if you track their returns from that day, the day they crossed that $100 billion mark against the S&P 500, and you include a total return, so dividends for each, almost none of them have actually gone on to outperform the S&P 500 from their total returns. Only Johnson & Johnson and now Moderna have done that. Of course, Moderna has a very small sample size. We're tracking, it's about 2 months from the time it hit a $100 billion mark. All of these other companies also outperformed the S&P 500 in their first 2 months after reaching a $100 billion valuation. So if we look over there on one of those columns about the revenue, and this is really what it all comes down to, there is kind of a limitation. There's a ceiling on drug developers. These aren't tech companies. They have drug revenue. Drug products will ramp in the marketplace. They'll generate, hundreds of millions or maybe billions of dollars if you're lucky. But eventually, there's competition, there's new technology, there's new drugs, there's whatever it is. So eventually your new products are just generating revenue that's replacing revenue that's from older products. So there is that ceiling. And this is something that I don't think people really understand for Moderna. And it's going to hit this ceiling much more quickly because, 2-3 years from now, we're not going to need, hundreds of millions of doses of coronavirus vaccines. So the company's going to have a really tough time replacing, 10, 15, maybe $20 billion of revenue come 2024, 2025. It's up, the rest of its pipelines in the early stages of development. Those products are many years away from hitting the market if they do at all. So the valuation right now makes sense based on the revenue from this year and next year, but it's not a sustainable amount of revenue because it's coming from one product that's not going to be needed in 3 or 4 years. So investors do have to keep that in mind.
And Max, we talk a lot about Moderna and Pfizer and Johnson & Johnson to a lesser extent for obvious reasons during the pandemic, but without making it clear that none of these are recommendations. We're just talking about stocks here, or maybe they are, but we're not endorsing any of these particular stocks on the podcast here. There are other players in the mRNA space, right?
Yeah, and so this is the thing. Like I showed you that the chart we just looked at with all the drug developers that have ever reached a $100 billion market valuation. The difference with Moderna, and this is probably going to be true for other genetic medicine modalities as well, is that it's a technology platform, right? It's mRNA. So we can throw that at infectious diseases. They're maybe thinking about throwing that at certain types of cancers. They can use it maybe for protein replacement for rare diseases, maybe even some common diseases. So you can deploy this technology broadly across a lot of different therapeutic areas. That's a difference from what maybe, Eli Lilly or Merck or Johnson & Johnson have. So theoretically, like, that's an advantage. And over time, I think some of these companies could set a higher ceiling than we've seen in the past. So companies with technology platforms. The other thing to think about, though, is, when you have a technology platform in genetic medicines like mRNA, RNA interference, gene editing, anybody can use those tools, right? Yeah, sure, there's IP, but for the most part, it's very easy to reproduce those results. So there's a lot of companies that are using mRNA, and we've seen just recently a lot of acquisitions. So obviously we have Moderna, and then we talk about Pfizer, but that tech actually came from BioNTech. It's a German company. It's actually also publicly traded. So that ticker is BNTX. It also actually reached a $100 billion valuation this summer, shortly after Moderna. So those are the two that developed these, vaccines that we have now, obviously. But then there's a lot of others. I mean, Merck went out and acquired Amtech. Sanofi went out and acquired Translate Bio just a few months ago. CureVac is another one working on mRNA. There's Arcturus, another publicly traded company. And there's a whole host of privately traded companies. For instance, Replicate is one kind of similar to Arcturus. They have something called self-replicating, self-amplifying mRNA technology and tools. That just came out of stealth mode with some money recently. So there's going to be a lot of players in this space. And, again, like, we're going to use mRNA for like the flu vaccine eventually, right? That makes total sense. It's way easier to use. You're probably going to get better results, way easier to manufacture. But we're also going to have like a half a dozen or more flu vaccines based on mRNA. So it's not just going to be Moderna that has the whole market opportunity to itself, or just BioNTech or Pfizer. There's going to be all of these companies trying to get their piece of the pie as well.
Max, let me ask sort of one last question from an investing point of view here. We don't talk about selling all that much, but if you look at one of these companies and they get to that 100 billion mark, do you then look at like the long-term viability of what they have coming to decide if maybe that's a sales point, maybe that's a goal line that they're not likely to stay at?
Yeah, I don't know. It's tough, right? Because historically, companies that have reached that milestone, that $100 billion mark, in the long run, they don't tend to actually outperform the S&P 500. And that makes sense, again, in the context of drug developers are not tech companies, and a lot of the S&P 500's returns now are driven by tech companies that don't have the same capital constraints. They have much different operating margins. They can scale much greater levels than a drug developer can. They're less regulated as well. So, I mean, I don't know. I guess I would stop short of saying you should sell a company, a drug developer, just because it gets to a $100 billion market valuation. But this does affect how I go about investing in the space. I tend to look at companies that are much smaller than that, because I keep that in mind. Once the company gets to a certain market valuation, even in the tens of billions of dollars, it is harder, because that's factoring in, expectations for drug revenue from products that may or may not even be on the market yet. So your returns are going to be limited at a certain point. So that's why I tend to just look at smaller companies that are less proven. That seems to be when most of your returns are or you have the best returns, rather. So again, like, if you invested in Moderna a year ago or 4 years ago, then you don't really have no reason to sell right now, right? But if you invested 3 weeks ago and you think it's going to just go to a $1 trillion market valuation or something, I have some bad news for you.
I look at it a little bit like the way I look at the movie business, that unless you're Disney, which has these sort of cornerstone IPs that you can just kind of mine forever, the number 2 player is Comcast. And Comcast, like, their top franchise, like, probably doesn't even like make it into like a Disney theme park. So I understand drugs are different because there's exclusivity period. Like, you control the Avengers for like 200 years. You don't control a drug for that long. But that is sort of how I view it, that this is a space that looks like there's a ton of opportunity. And there is, but there's also a ton of losers and a ton of, especially we've seen this during the pandemic, fool's gold. Oh my God, this company might come up with a COVID, whatever, a magic COVID detector, and the valuation jumps up by, $500 million in a weekend. Well, that's not really how these things work. We're going to move on to our third story here. And I don't know that much about this one, Max, but AbbVie is getting back into gene therapy. Why don't you explain?
Yeah, so we just talked about $100 billion drug developers. AbbVie was one of the last before Moderna to reach that mark. I think it was in like 2013 or 14. It was in that graphic. But AbbVie is getting back into gene therapy. Just today, it announced a new collaboration with a company called REGENXBIO in a gene therapy to treat eye diseases. So REGENXBIO is developing enhanced viral vectors. These are kind of like the delivery vehicles we use to package and encapsulate therapeutic payloads in gene therapy. So it's kind of it's working on enhanced viral vectors that can get to different tissues and overcome some of the challenges we've seen with those viral vectors in the past. Now, its lead drug candidate is RGX-314, and this is actually at the center of the deal with AbbVie. It's aimed at treating wet age-related macular degeneration, or wet AMD. And this causes blurred vision. This gene therapy be used to treat other eye conditions as well, not just wet AMD, but maybe things like diabetic retinopathy and so forth. So this provides a copy of a protein to patients in their eyes, and it blocks the VEGF protein. So this is actually a well-validated target. There's current treatments on the market today. They're antibody drugs. So they block this protein, and it prevents the formation of abnormal blood vessels and leakage from those that eventually lead to blurred vision and these eye diseases in general. So these antibody drugs generate billions of dollars a year in revenue. But of course, you need to get injections into your eye every month or every so many months. That just makes me squeamish to think about. So the promise of a gene therapy is that it's a one and done treatment, or maybe you only need it one every so many years or decades, maybe if we can redose it. So a lot of potential there. So AbbVie's back in on gene therapy is kind of really the bigger news story, I think, of this morning. In about a $1.8 billion deal, I think, is the total consideration. Gave up about $350 million up front. So that's a big haul for REGENXBIO, which is a relatively small company. And this is AbbVie's first foray back into gene therapy, I think, since it was working on neuroscience indications with a company called Voyager Therapeutics. And then it backed out not very long after that. So AbbVie's back in gene therapy, Dan.
Max, let me jump in with one last question. Is this just endemic of the space that you constantly have to be investing in some of these smaller companies or making deals or making acquisitions?
Yeah, I mean, that's the thing. So AbbVie is a good example, actually, for Moderna investors to consider, right? I think 35% of its revenue comes from Humira, which is I think it's the top selling drug in the world right now, soon to be Keytruda for Merck. But so Humira is going to lose patent exclusivity. And in 2023, July 1st, 2023, mark your calendars. A lot of biosimilars are going to be launching in the United States, and AbbVie's dominance for that drug will be no more. So AbbVie has to replace that revenue. It's going to be losing a lot of revenue. It's like 16, I think in 2 years, it might be $18 billion per year. So it needs to just go and invest in what's the next thing, what's the next blockbuster drug, how do we generate billions of dollars more to replace that revenue we're going to start losing here in a few years. So this actually fits in nicely with the other topic we just talked about today.
This was a crash course on 3 topics. We appreciate you putting up with us. We promise on Friday we'll get back to a fully interactive show. Max, thank you for getting through this quickly. Let's hit our finisher. And this one is a doozy. This one got a lot of votes online. If you want to pull this up, JT. And we got to work on getting these graphics scaled properly. How do you feel about investing in Chinese stocks? 22.7% of you, 0.7% of you said buy, 50% said sell, 27.2% said hold. Max, this might be true for you too. I don't own any Chinese stocks because generally, if I don't understand the culture of a place, I'm not going to invest based on market and potential alone. And the political part of it has always made me squeamish, which seems to be getting worse right now. So for me, I can't buy, sell, or hold. I never owned any of them. What's your thoughts here?
Yeah, I've stayed away from China. That's one of the red lines I don't cross in my own portfolio. And I've had a tinfoil hat on when it comes to Chinese stocks for many years. And now I'm being vindicated in 2021 finally. So I don't look so crazy anymore. But yeah, I just there's too much risk there, and it's different kinds of risks, right? It's geopolitical risks, or again, just how the federal government there works and what their goals are for society. So much different here than in the West, and as we've seen, that can change fortunes of companies overnight.
This is, of course, not a simple topic, and it is one we are going to revisit with Simon Erickson, Steve Symington, Anirban Mahante, maybe Matt Cochran even. They all know more about this than we do. We appreciate you listening to what is a short show for us. Usually we do about an hour, though in the beginning we did shows of this length. We hit 3 topics. We really appreciate you being here. If you'd like to get in touch with us, that is info@7investing.com. That is questions about your membership, questions about the service, questions you'd like to ask one of us. Don't ask us to work up a penny stock we've never heard of, but certainly if you ask us about a stock that we've done a lot of work on, perhaps we'll have an answer. If it's one we've talked about on the show and you want to know something more about it, we're usually happy to answer those questions, though we might do it on a live show. If you'd like to interact with us on Twitter, you can do that at 7investing. We are a lot of fun to follow. And of course, if you're bored in the next few days, follow me on Twitter at worstideas7, because I will be sending you pictures from all of the various beautiful places I am going to be. Lots of islands, lots of beaches. Maxx Chatsko, thank you for doing this. JT Street, Sam Bailey, thank you for all the work behind the scenes. We will see you on Wednesday with Anirban Mahante, and then back on Friday with pretty much the entire team. See you, everybody.